Because of the importance of a reasonably detailed knowledge of anatomy, I will try to describe some of the important anatomical relationships in some of the more common forms of lameness. We will begin with the carpus. This shows the bony outline of a carpus. Here you can see the accessory carpal bone. Now the accessory carpal bone is sometimes fractured, and signs of fracture of this bone include distension of the carpal sheath that comes in behind the accessory carpal bone, in the groove behind the bone, and pain when the limb is flexed. So whenever distension of the carpal sheath occurs in this area, be sure that you radiograph for a possible fracture of this bone. Also notice the ligamentous attachments of the accessory carpal bone. Occasionally we will see rupture of this ligament here tying the accessory carpal bone to the radius. And of course this causes a painful form of lameness, and on radiographic examination we will see separation of the accessory carpal bone from the radius at this point in here. This bone is called the pisiform bone in the English literature, and when you read about lamenesses due to this in the veterinary record or the British Veterinary Journal, you would recognize it as a fracture of the pisiform bone or injury to that bone. Let's point out too now the collateral ligaments of the carpus. These are sometimes sprained and sometimes occasionally ruptured. Notice the comparative strength of this lateral collateral ligament of the joint as compared to the medial. Notice that the medial ligament is much thicker and much stronger. However, peculiarly enough, this is the ligament that is most commonly ruptured, the medial collateral ligament. This is almost two separate ligaments, since we have one coming along here and tying in to the proximal row of carpal bones and then to the radius, and then the one coming from here has almost a twisted effect, coming down and tying in to both rows of carpal bones and then into the splint bone in here and to the radius in here. So this ligament is, even though it's larger and stronger, is more commonly ruptured than the lateral collateral. If we can have that's fine, a fairly open shot here. Now this groove in the radius here is for the extensor carpi radialis. And this comes down across the front of the carpal bones and inserts here on this prominence in the third metacarpal bone. Occasionally that tendon is ruptured, in which case we can feel an absence of the tendon as we flex the carpus and palpate in the area where it belongs. Eventually we'll see considerable atrophy of the muscular belly of that muscle, and when the horse moves there will be an overflexion of the limb, because the limb does not have the resistance of the extensor here to the flexors. So the flexors have more action and pull the limb up into a higher flexion. The lateral and common extensors will still extend the limb, and so there's no trouble in extension to set the foot down. Fractures, chip fractures in the carpus are relatively common. Here the radial carpal bone is one of the most common ones fractured. They fracture chips up at the proximal aspect, at the distal aspect in here. The third carpal bone is also very commonly fractured, and chips may occur on this proximal border, or we may get slab fractures that from about here on across form a slab in this way. And those require a bone screw to be put in at this point to fix the fracture into position. So bone screw here to fix a slab fracture. Chip fractures are surgically removed. The intermediate carpal bone is sometimes fractured also, and this is a more difficult surgical approach than it is for the radial carpal bone. And on the radiographs, as you might see from this view here, there is on the lateral view great difficulty in telling whether or not the radial or the intermediate is fractured. So we must use different oblique views to determine which one is fractured. Now this, on your radiograph, would be the medial oblique view. Try to get this in a more exact position. On the medial oblique view, on your radiograph, you can see the curvature in the accessory carpal bone. Notice how this outlines the radial carpal bone, and so when you see the chip fracture on this view, either here or down here, then you know that it's the radial carpal bone. As we move to the lateral view, then there is some problem. So if on the open lateral view and on the straight lateral, or I should say the flexed lateral view, and on the straight lateral view, if the chip is seen but not seen on the medial oblique, you must consider the possibility of an intermediate carpal bone fracture. And the lateral oblique view, which would appear like this, would help to outline this fracture on the intermediate carpal bone. So be very careful in diagnostic interpretation of chip fractures between the radial and intermediate carpal, especially when you cannot see the fracture on the medial oblique view. That is for radial carpal bone fracture, and this view shows up better the intermediate carpal bone fracture. Now, more rarely we will see chip fractures from the radius at these points here, right in here, and right in here. And very rarely we'll see a chip fracture off of the third metacarpal bone in this area, right in here. And all of those are surgically removed. Now we will go to a different specimen. And the first thing we will point out here is the area of splints. Now splints occur between the second and third metacarpal bones most commonly. Of course, they also can occur on the lateral aspect between the third and the fourth metacarpals, but the medial aspect of the limb is the most common. This is the second metacarpal. This is the third. This is the line of junction. This is the area of the interosseous ligament. Interosseous ligament. And in young horses, when that ligament is disturbed, it forms new bone growth to help tie the splint bone to the cannon bone, or the second to the third metacarpal bones. A periostitis results, a painful swelling results, and the animal must be allowed sufficient rest to allow it to heal. And now, when these splints, so-called, occur in several areas up and down the limb, those are called chain splints, because they occur in numerous bumps up and down the limb. A high splint is one up close to the carpus. A high splint is one close to the carpus, up in this area in here. This endangers the carpal joints, and when and if they invade the joints up here, the prognosis is very unfavorable. Now, sometimes these so-called splints are not splints, true splints at all, but are due to trauma to the cannon bone from interference from the opposite forelimb. The hoof wall can hit the cannon bone here, producing a bony swelling that is very similar to a splint. One can aid in determining this by putting chalk on the inside of the hoof wall and moving the animal in circles and quick turns, and see if chalk shows up on the hair over the bump. If so, one must consider the possibility of a broken splint bone or a metacarpal periostitis from trauma. A broken splint bone is usually from interference and can occur in a horse of normal conformation on a quick turn where he comes across with the opposite foot and hits this splint bone very sharply. Now the fracture can occur anywhere from the tip of it down here all the way up to just under the carpus in here. Now the usual treatment for fracture of the splint bone is to remove the fragment distal to the fracture. However, I have found that in fractures that occur way up in here, that I can remove the exostosis and the involved portion and leave the distal fragment here with no bad results from leaving the fragment, because as you can see, there's plenty of vascularity coming in to this bone to nourish it. However, whenever the fracture occurs down in this area, then we go ahead and remove all the distal fragment. This is done by incising down through skin subcutaneous tissue, through the periosteum. Ordinarily, we reflect the periosteum and then remove this bone and taper the upper fragment so that it's not sharp against the skin area. Now, fractures of this bone will usually heal, but they take more time to heal by callus formation than they do from surgical removal, and that's why in racehorses many times they're removed rather than wait for a callus formation. Another common lameness in racehorses is so-called shin buck. And this is a metacarpal periostitis of the third metacarpal bone. Can we open this shot up a little bit to better orient us? Here's the fetlock joint here, in the front of the cannon bone, or front of the third metacarpal bone, and shin bucking is metacarpal periostitis in this area. We do not necessarily know why it occurs. We do know that in some cases, and perhaps most cases, there is a so-called saucer fracture in this bone, a longitudinal type fracture that you can see on the lateral view, and it may be a small saucer fracture or it may be a long saucer fracture. And the saucer name comes from the fact that it's curved. And so actually it is or perhaps is due to a crack in the cortex of the bone, and this of course would be from concussion trauma, and it's limited primarily to 2- and 3-year-old horses in heavy training. Now, in this area is the volar pouch of the fetlock joint capsule. This becomes distended whenever there is an articular lesion, like a chip fracture of one of the sesamoid bones here, or a chip fracture of the first phalanx up in front, or an arthritis in the joint, or the so-called osselets, which is a traumatic arthritis. The joint capsule can bulge through here in the volar pouch. This is the suspensory ligament. So your identification of the area is the suspensory ligament behind and the third metacarpal bone in front. The suspensory ligament behind, the metacarpal bone in front. Here, between the suspensory ligament and the flexor tendons, is where swelling occurs from distension of the tendon sheath. So your landmark between them is this suspensory ligament right here. And this is also the surgical approach for removal of apical fractures of the sesamoid bone. The incision is made between the suspensory ligament and the cannon bone through the volar pouch, and going down and incising partially through the collateral ligament of the sesamoid bone to the cannon bone. This will expose the proximal end of the sesamoid bones, and we can remove some basal fractures of the sesamoid bone that go into the articulation. For other fractures of the sesamoid bones, and you can see the sesamoid bone here, we either incise directly over the basal fracture, or we incise through the tendon sheath, or the annular ligament first, then the tendon sheath, and then pull this tendon here to the side, pulling it over in this direction with a retractor, and then incising the distal sesamoid ligaments transversely in this direction to remove that basal fracture. Now, one lameness that is, although not common, is very vexing, is a constriction of the volar annular ligament. And we have a pretty good view of it here. This is a volar annular ligament here and over here, and it's been cut in two. Now, lacerated wounds into the pastern area on the posterior or volar aspect often wind up with a constriction of this volar annular ligament. And that cuts into the flexor tendons here and causes a chronic persistent lameness. And the treatment consists of incising down through the volar annular ligament and on into the tendon sheath, because in the presence of inflammation and scar tissue, the tendon sheath and the volar annular ligament are tied together so tightly you cannot separate them. And so you just cut it in two, then suture the subcutaneous tissue and skin, and put the animal in a supporting wrap. And by breaking this continuity between the volar annular ligament, then the tendon has more room and the lameness will disappear. Now, so-called bowed tendon, if we can open up a large view between here and here, please. Bowed tendon is a injury or strain to the tendon anywhere in this area. A high bow occurs in this area, and the carpal sheath will cover the tendon down to about this point. You can see the edge of the carpal sheath right here. And so this area is called a high bow, a middle bow in this area, and a low bow down here, which may extend on into the volar annular ligament, as we previously showed. This must be differentiated from, and sometimes occurs in conjunction with, injury to the suspensory ligament. Here's suspensory ligament, here are the flexor tendons. The superficial tendon is usually damaged first. The superficial flexor tendon usually is damaged first, and in many cases is the only structure damaged, but the suspensory ligament may occur separately or along with it, and both tendons are involved, ending up in fibrosis of the tendon sheath to the tendon, and we have a tendosynovitis. Injury to the suspensory ligament most commonly occurs in the V-shaped area. Let's see if we can get a little better view of that. I guess we can't show it too well. We'll show it on another specimen. But at about this point, the suspensory ligament divides between the junction of the distal and middle 1/3 of the cannon bone, and this is one branch of it right here, coming to fasten to the sesamoid bone before it goes on over and joins the common extensor on the forelimb and the distal part of the first phalanx. Here you can see the branch of the suspensory ligament coming into the common extensor. Notice how the common extensor tendon fans out. Notice it's narrow down to this point and fans out and is buried into a considerable portion of the first phalanx, all of the second phalanx, and then on into the extensor process of the third phalanx. The disease called navicular disease occurs in here. Now here is the navicular bone with the navicular bursa behind it and the deep flexor tendon here. And the deep flexor tendon is forced up tightly against this bone when the animal is moving. And if the animal is, just as the weight leaves the forelimb, the tendon here is very tight against the navicular bone. This bone, this bursa becomes inflamed, and in the presence of inflammation, the navicular bone demineralizes, and you have a chronic, persistent, incurable type of lameness. This is third phalanx. This is a second phalanx here, and navicular bone here, navicular bursa, for orientation purposes. Now, the navicular bone is suspended in a ligament called the suspensory ligament of the navicular bone, or the T ligament, that attaches all along the top side of the bone and from the edge here, and goes on up and underneath and attaches to the distal end of the first phalanx, clear up in here. So this bone is suspended by a ligament clear up into the distal end of the first phalanx. Now we'll move to another specimen. Before I do that, I better demonstrate one difference I wanted to show in the lateral digital extensors. Here we have the extensors of the forelimb, the common extensor tendon here. You can see it coming down here. And the lateral digital extensor tendon here. And the lateral digital extensor in the forelimb comes down and inserts in the proximal end of the first phalanx. Can we open that shot up some for a little better orientation? Let's show the edge of the hoof wall. That's fine. Common extensor tendon here. Lateral extensor coming down to insert anterolaterally on the proximal end of the first phalanx. In the hind limb, the lateral extensor, it's a little bit dark, but for maybe I can bring it up closer. The lateral extensor here comes down and inserts into the long extensor. This is the long extensor here. This is the lateral extensor coming down to join it. Now this horse has almost a separate head of the long extensor. Most horses have just the one long extensor and then a lateral extensor coming in. Notice that this portion here probably is long extensor and not lateral. Notice the complete separation up here in the two areas they come from. So the lateral extensor comes down this area, and this is the tendon that is cut in string halt and removed from over the surface of the joint. While we have the hind limb, we will demonstrate bone spavin. Bone spavin occurs on the anteromedial surface of the hock joint. Here we have the central tarsal bone, the third tarsal bone, and the third metatarsal bone. The tibial tarsal up here, and the first and second tarsal bones right here, with the second metatarsal bone here. So spavin, bone spavin as such, involves most commonly the central, the third, and the third metatarsal bones. Central tarsal, third metatarsal. And this is the area most commonly involved. With the tarsal metatarsal joint here and the distal intertarsal joint here most commonly involved. This joint, the proximal intertarsal joint, is not so commonly involved, and the prognosis is more unfavorable when that happens. Now, we hope to attain ankylosis of this distal intertarsal and tarsal metatarsal joint. And sometimes nature does this. Sometimes we stimulate it by drilling in those joints with a bone drill to help fuse those joints. Another common treatment is to fire into these areas to produce a periostitis. And sometimes in incising the cunean tendon, the knife is incised into the periosteum deeply to try to produce enough periostitis to cause fusion of this joint and this joint. Distal intertarsal joint here, tarsal metatarsal joint here. Now the cunean tendon comes across here. I think we need now here is the area of bone spavin right in here, and a bursitis develops under this cunean tendon, and when we take out, we cut it here and we cut it here, we take out a section of it, then we relieve the pain of that bursitis, and so we may aid the horse as far as lameness is concerned by relieving the bursitis. But most horses have to fuse that distal intertarsal and tarsal metatarsal joints before the lameness is cured. So now this tendon, if we can open the shot up some now, this cunean tendon is a portion of the insertion of the tibialis anterior muscle. Yes, tibialis anterior muscle. And the other portion of that tendon comes down and inserts into the proximal end of the third metatarsal bone. So this is just one of the insertions, and the horse does not miss it. Now, with this plaster of Paris specimen, we can review some of the things we've talked about. The suspensory ligament in here, the flexor tendons here, or the superficial here and the deep here. Now, this represents the volar annular ligament. And this is the ligament that we cut when that ligament is constricted from previous injury, from wire cut or infection of any type. Or sometimes in bowed tendon, in low bowed tendon, the inflammatory process spreads from the tendon and tendon sheath down into that ligament and involves it with adhesions and scar tissue. So it is incised, and that relieves the pressure. Now we will remove this section, which represents the flexor tendons. And if we can show in behind here, sometimes a similar type of injury that occurs to the suspensory ligament occurs to the distal sesamoidean ligaments. There are three main distal sesamoidean ligaments. This represents, now we better open that up just a little bit, I think, so we can keep a good orientation here. This represents the superficial or the straight ligament, or the Y, superficial, straight, or Y. And it inserts down here at the proximal end of the second phalanx. It comes from the base of the sesamoid bones, the intersesamoidean ligament, and down to the proximal end of the second phalanx. Here you can see the middle or oblique or V. You can see how it gets the name V ligament by the structure in here. And it comes from the base of the sesamoid bones, the intersesamoidean ligament, and inserts on this V portion on the posterior aspect of the first phalanx. Underneath that, of course, and up in deep here are the cruciates or X or deep sesamoidean ligaments that insert from the base of the sesamoid bone and come across to insert into the top of the posterior aspect of the first phalanx. So these structures may also suffer the same type of damage. They'll be swollen and inflamed, and scar tissue develop in them, and as will develop in the suspensory ligament when it is injured. And this is most common in pacers and trotters. And I'll put this back again so you can see with the straight ligament in place for review. The straight, superficial, or Y, the middle, or V, or oblique, and then the cruciates deep to that. And the straight and the straight ligament here and the middle or oblique ligament are most commonly damaged. Now this structure right here represents one of the collateral cartilages. And involvement of this through a wire cut or other trauma, or sometimes from causes unknown, represents a disease called quitter. And quitter is necrosis of this collateral cartilage. And to take care of that, we must make an elliptical incision in this area and follow the draining tracts out and remove all parts of necrotic cartilage. We'll remove that cartilage. And here we can graphically demonstrate the digital cushion. This represents digital cushion. And digital cushion will quickly dehydrate and atrophy in the absence of frog pressure. So regardless of the cause of the lameness, when the animal is not properly using the limb, this digital cushion will atrophy. And it is very difficult to get it back to its former size and function. One of the functions, of course, as it's compressed, is to press on this collateral cartilage and force it outward to help force the blood up the veins in this area. The veins in this area have no valves, and the outward movement of the collateral cartilage caused by this digital cushion will help pump the blood up these veins. Now, in the disease called laminitis, there is separation of the laminae, the sensitive laminae here, and the insensitive laminae on the hoof wall in this area. So there's separation between here and here. This is probably caused by inflammatory edema from the laminitis. With the separation and edema formation between these two sets of laminae, plus the pull of the deep flexor tendon, which is going down here, right in here, when it attaches to the, let's see if we can demonstrate it a little better. Here comes the deep flexor tendon here, and it attaches into the third phalanx here. And with the pull of this tendon, plus the weakening and separation of the laminae of the third phalanx here to the laminae of the wall, the pull of that tendon on the third phalanx will cause rotation and pulling, and that accounts for the rotation that occurs in the disease called laminitis. So, regardless of the cause of laminitis, edema, inflammation of these laminae, we can see them both here, sensitive laminae on the third phalanx, insensitive laminae on the hoof wall, weakening their attachment, plus the pull on the third phalanx by the deep flexor on the third phalanx causes the tip of the third phalanx to rotate downward and point more straight up and down. This, we can get some idea of the spine of the frog in here. Maybe we can turn it sideways. The spine of the frog that comes up and presses on the digital cushion to help cause a normal expansion of the foot. This concludes the discussion of anatomy of some common lamenesses in horses.